And our first session is the Project 1, which is the quantitative baseline assessment of child nutritional status and performance of ICDS supplementary nutrition in Bihar by Neil Buddy Shah, who's on my right, and Ronald Abraman, who's on his right. I'd just like to introduce the two speakers. Neil is a founding partner at IDinsight. He's worked previously with the World Bank's Governance and Public Sector Reform Unit and MIT's Jameel Poverty Action Lab. He has experience in Cambodia, India, Zambia, and Uganda, working on governance reform, health, education, and sanitation. Ronald is IDinsight's country director for India, managing the organization's engagements and future growth in the country. He has significant experience in education policy research and program management. Previously, he worked with Pratham and managed a statewide learning excellence program in collaboration with the government of Punjab, covering 13,000 schools. So with these words, I would request Neil and Ronald to begin. As we are slightly short of time, and the session is so structured that 25 minutes for their presentation, another 25 minutes will be for Project 2. I'll introduce the speakers at that point of time. And then we'll have discussants. We'll see who are the discussants at the, later, 10 minutes each, and a question and answer session of 10 minutes each. I pride myself on execution, which means that I'll guillotine anyone who goes over the time. So please start.
Can you hear me? Okay, great. Good morning, everybody. A big thank you to IGC for hosting the event, for inviting us to speak here, and of course for supporting our work with the Department of Social Welfare and ICDS. It's also a great slot that we're speaking on. I wanted to remind everybody that right now millions of children across Bihar are sitting at their Anganwadis, awaiting a hot cooked meal, and hopefully in some of them there's also some innovative preschool activity that's happening with them. So while we're sitting here discussing about the issues with ICDS, it's good to know that the work is going on simultaneously. I wanted to start by just laying out the agenda for today. I'm going to begin with the context of the work that IDinsight is doing in Bihar, why we're here, and what is the work that we're doing with ICDS. After which I'll discuss the findings of our study, which is a quantitative assessment of the status of ICDS, specifically looking into fund leakage, the status of public service delivery, and malnutrition. After which I'll briefly describe the proposed policy interventions from the ICDS leadership to address some of these issues. Buddy, my colleague, is going to take over from me after that, and he's going to discuss the learning and evaluation approach to that we are adopting to help the ICDS leadership choose the best policies and the best policy designs to maximize the impact that they can have on the ground. So with that, let me start with the context. As many of you know, ICDS is functioning in about 90,000, has about 90,000 Anganwadis, which are equivalent to a daycare center all across in every remote corner of Bihar. They work on nutrition, health, immunization, and preschool education. And specifically on nutrition, the program last year spent about 1,100 crores on providing support to improve what's happening on the ground. And they've brought in IDinsight as a development partner to engage on specifically 4 things. One is to diagnose and quantify the performance of ICDS and whatever the shortcomings may be. To help ICDS refine the policy designs, the policy interventions that they've proposed, to rigorously evaluate these designs, to test the efficacy, and to understand the cost versus the benefits, to really figure out which one of these interventions, if one or two, should be scaled up across Bihar. And finally, to also support the scale-up of policy interventions that have been known or proven to have worked. Because IDinsight does not want to just come in and just provide a report, and we were also, we were asked that it's one thing to come in and say what the performance is like, but you need to engage as a partner to sort of help improve the status quo on the ground, and that's what we're looking forward to doing with ICDS in the future as well. And we've done so in the past and in the future as well. Before I go on to the main findings of our study, I just wanted to elaborate on the methodology a little bit. The question we're asking is, what is the status quo of public service delivery in Bihar ICDS? And what is the nutritional health status of children and mothers in Bihar? To do this, we are conducting random unannounced visits to Anganwadis. And when we did these visits, we went between 11:30 and 12:30 to ensure, A, that the Anganwadi should definitely be open at that time, B, that they should have started cooking food by that time, and C, the food that they've started, they should have committed the ingredients so that when the surveyor goes, it does not change what was already, it does not change the situation on the Anganwadi at that day. We, of course, interviewed Sevikas, but we also interviewed the beneficiaries to understand their own assessment of their local service, their local Anganwadi, and to understand their food consumption patterns in the family. We also interviewed shopkeepers. It's important to understand that the Anganwadi Sevika is the one who's actually going to the market and buying foodstuffs. And therefore, there's a constant interaction with the local market. So understanding, getting price intelligence from the local shops was critical for us to create a full picture. We did this study across 200 Anganwadis in 200 panchayats, spread across 20 blocks in 3 districts. We chose the districts to be careful that they were fairly representative of the state of Bihar. We ensured the districts were from different linguistic traditions in the state, and that the characteristics of these 3 districts, such as literacy, mortality, match closely with the average characteristics of the state of Bihar as well. So with that, I wanted to move on to some of our findings. We find that about 71% of the budget on hot cooked meals are lost in leakage. Hot cooked meals are provided to children between the age groups of 3 and 6 at Anganwadis, and there's about a budget of about 4,600 rupees per Anganwadi per month towards this. Now, while 71% is the sort of the major top line figure, we also tried to break this down a little bit. I'm not sure if the graphs are clear. Can everyone see the graphs? If not, I can just read out the numbers as well. 24% of the money spent, 24% of the budget was lost due to leakage simply because the Anganwadis were closed. So when we visited, we found that some of the Anganwadis were closed even at 11:30. 18% of the funds were lost to leakage because while the Anganwadi was open, it was still not serving a meal or was not even preparing a meal when our teams arrived between 11:30 or after. And about 26% was lost to leakage due to child attendance. So we found that child attendance was about half of what is usually reported. And 9% was lost to leakage due to ingredient utilization, underutilization. One of the things I forgot to mention is that we also supplied, we also tested the food stuffs that at the Anganwadi. We tested, at a nutrition lab, we got them tested for protein and calories to understand what was the extent of these nutrients in the food, from which we also got to back calculate the amount of rice and dal that the Anganwadis were using. That allowed us to look at ingredient utilization. At the end, you see a green blip, and that's because that's additional expenditure that is being done by the Anganwadi, and that's because the budget had specific prices at which they are supposed to buy foodstuffs, except for 20%. Except for the cost at the market was about 20% higher, which meant that there was an additional expenditure of about 5 percentage points. This is important to note because while there is a notion that because there's a huge discrepancy between the market prices and the allocation from ICDS, it only contributes to a small fraction of the story over here. We similarly find that about 38% of the funds allocated for THR, that's take-home ration, is also lost due to leakage. THR is essentially dal and rice provided to children and mothers once a month as raw food to supplement their nutritional intake. This particular graph over here is specifically only for dal. I haven't put up the graph for rice because the numbers are roughly similar. We see that about 16% is lost due to leakage because THR was not provided. We see about 38% was lost due to leakage because the volume was not according to the stipulated amounts of the Anganwadi system. But we also see that because dal is extremely expensive compared to what has been allocated in the budget, there was also an additional expenditure of 14 percentage points. I do want to stress here that what we've done is essentially quantify and provide a little bit more color to what the ICDS leadership already knew. And that's exactly what they asked us to do as well. They wanted to understand the extent of the problem in a scientific way. Everyone knew there was an issue of leakage, but they wanted to get a quantitative understanding of that. And they also wanted to figure out the components of this leakage, to figure out what are the key public service delivery issues that is contributing to this fund service, to the leakage on the ground. The Supreme Court of India guidelines suggest that the food that the child is having every day is supposed to have about 500 calories, about 12 to 15 grams of protein. We found that roughly 77% of these requirements are being met when the children are fed. Attendance, as I said, is about half of what is reported. The attendance of the Sevika and Sahayika when they're both present is 40%. But at least at 75% of the time, at least one of them or both of them are present. We found that learning activity was not taking place in 71% of the Anganwadis that were open. 71% of all Anganwadis. Now this is important to note because the Sevika is in charge of the preschool education, whereas the Sahayika, her helper, is in charge of providing, is in charge of doing the cooking. So ideally, while the Sahayika is doing the cooking, the Sevika should be engaging in organized activity, and that's not being taking place. And because there's a lot of focus on nutrition, and there's a little bit more focus that needs to be put on preschool education. Finally, I've been discussing so far the processes and the inputs that have gone into ICDS. And of course, what everyone here cares about and what is clearly evident from previous studies and also comes out in our study is that the status of nutrition, both for children and mothers, is extremely grim in Bihar. We find that about 43% of the children are underweight and about 39% of the mothers are underweight. So roughly in both cases, 2 out of 5 are underweight. This is very similar to, these findings are very similar to a study by Hangama that was done in the previous year. And what is good to note is that this is a significant decline from 2005-06 because the NFHS study was reporting a malnutrition rate of about 56 at that time. And now there are our study and another study that basically says that at least that has come down from 56 to 43 since 2005, which is definitely very encouraging. Any story about the situation on the ground not being ideal needs to be accompanied with the fact that is also very true, which is reform is excruciatingly difficult to enact. Now there's a supply side story here. One, so this is the ICDS leadership. These are the issues that the ICDS leadership are facing. For example, ICDS is severely understaffed and under-resourced. to just give you a sort of a anecdote, just sort of a number to highlight this, the ratio between ICDS management staff at the state, district, and block level to the ICDS ground level staff is about 1:30, whereas the ratio of another organization which sells soap, which is Hindustan Unilever. Now, Hindustan Unilever just has to sell soap. ICDS has to take care of nutrition, immunization, child health, maternal health. And so while Hindustan Unilever has a very simple task, the ratio that they have between their management and field staff in Bihar and Jharkhand is 1:3. So 1:30 is ICDS and 1:3 is a private sector company. And of course, the comparison is not valid. They have more funds, they're making money. But it is important to understand that this is not an easy job when you have a huge a huge force, about 1.6 lakh people on the ground, and you have to monitor their work. To add to that, the accountability mechanisms to work with these individuals is missing largely. It's difficult to reward good performance. It's difficult to penalize bad performance. And there's been an entrenched equilibrium of non-performance that you have to deal with. There are Anganwadi workers and CDPOs who are used to the system not working and the system not challenging them. And to break out of that is very difficult. So the ICDS leadership, therefore, is severely restricted and does have constraints around their ability to sort of go through all the regulations and procedures and actually enact change. The situation on the ground also makes this difficult. The beneficiaries who can also be providing sort of the community or the citizen level monitoring are not as aware of their rights and entitlements. Sometimes the beneficiaries want to be in the good books of the Sevikas because they feel she controls whether the beneficiaries will get at least something out of the Anganwadi, so they're not challenging her. And finally, we find that a lot of mothers say that do not think that malnutrition is an issue. The Hangama study actually asked a question on this and found out that only 7.6% of mothers actually even know about the word malnutrition, ati kuposhit or kuposhit. Yet, it's important to note that despite how difficult it is to enact reform, ICDS is taking some significant initiatives to improve the status quo. I'd like to describe two of these initiatives that we are working with ICDS on. One is using technology to facilitate bottom-up and top-down monitoring of the supplementary nutrition program and other functions of ICDS. By this, I mean, so by bottom-up monitoring, what we're talking about is using a call center model to be able to give information to the beneficiaries about their local Anganwadi versus neighboring Anganwadis, to give information to the beneficiaries about their rights and entitlements, and to also solicit information about what is the performance of their local Anganwadi and what are their grievances. Can you also tell us about good stories? So there's basically, that is the citizen angle. And then by top-down monitoring, we're talking about using simple mobile smartphones to empower lady supervisors and CDPOs, that's the supervisory structure of ICDS, to be able to better monitor the functionings on the ground. With a mobile phone, we'll know that they are going and doing the monitoring duty, and it will improve the quality of their visits when they go, and it will improve the verifiability of their visits where they go, because there's GPS and phone cameras involved. The second initiative that we're doing is working on, I've worked with ICDS so much that I keep saying we. So the second initiative that ICDS is doing that we are supporting them on is working with Jivika self-help groups to take over the nutrition administration part of ICDS. So the self-help groups and the village organizations on the ground will procure the food and either cook the food or oversee the cooking of the food. And this is going to happen at a pilot basis soon and will be launched across Jivika blocks at some point in the future. It's important to note that while these are the two interventions that IDinsight is working with ICDS closely, there are a whole range of other initiatives that they're working on that that are listed up there. I now wanted to invite Buddy to take over and discuss how we are working with ICDS on these two things.
Thanks, Ron. My colleague's loquaciousness has left me with 5 minutes to go through the evaluation strategy, so I'll do my best. As Ron mentioned, we're working on these 2 interventions with ICDS leadership, and there are reasons to believe why they could be effective in improving the status quo. On the demand side, the Jivika self-help groups come from the communities in which the Anganwadi Center beneficiaries live, and so there's some probability that they'll start to educate the other mothers and families within those communities to better understand their entitlements and then demand that they're provided. Similarly, on the supply side, there's anecdotal evidence that within Jivika self-help groups, there's a lot of social capital and they're very high-functioning organizations, and that might translate into more successful delivery of the supplementary nutrition program. And for the technology-based monitoring program, especially the bottom-up component, there's a lot of reason to believe why giving information to beneficiaries on the functioning of their Anganwadi center compared to ones in the region, as well as information on their entitlements, is going to lead to an increased demand pressure to better supply the program. And on the supply side, better equipping lady supervisors and CDPOs with the right tools to collect actionable data that can lead to more consistent provision of SNP also leads us to believe that these interventions might improve the status quo. But at the same time, as anyone who's worked in Bihar or India knows, there are also reasons why these interventions might not work. The Jivika self-help groups have never really administered a large government program, and there have been a number of technology-based monitoring programs across India that have not been as successful as hoped. And so I think what this highlights is that there's a real need to have a robust learning and evaluation process in order to guide the ICDS leadership on which of their initiatives they should scale up and which ones just aren't going to work in practice. And that's really our role, is to support the leadership in helping to think through which of their proposed interventions are in fact successful. And the way we're doing that is sort of through a 6-stage process. Ron's already talked about the diagnosis of the system, and ICDS leadership came up with 2 main interventions. And where our role really comes in is to help the leadership refine those interventions through rapid field testing. And so this is distinct from rigorous impact evaluation. It's really about identifying the different design choices on a more granular level, so that when you do subject an intervention to a rigorous evaluation, it's most optimally designed possible. And then after rigorous impact evaluation through an RCT, guiding the government on which programs should be scaled up and supporting them in that process. And just to quickly talk about that 3rd step, which is refining interventions through short field testing of design choices, as Ron was describing these 2 interventions, the Jivika program as well as top-down monitoring and bottom-up monitoring, there's a lot of individual components of that have to be optimized. And the way that we're advising ICDS to do that is to actually try, within a short time period of 3 months, in a few blocks, actually test out these different design choices. Because we could sit here all day and argue about whether there should be decentralized or centralized feeding by the SHGs and Jivika, how information should be shared with the communities. But our view is that by actually trying it on the ground quickly, you get some indicative sense of which ones might be most optimal. And then after that field testing, the idea is to get set on a finalized intervention, which you then expose to a rigorous impact evaluation. And so the design of that rigorous impact evaluation, which is planned for the fall of this year, later in several months, again, is asking the question, what is the impact of transferring administration of SNP to Jivika on 2 outcomes, leakage of funds and child nutritional status? And the design is going to be a randomized evaluation with a universe of 200 panchayats, half of which are going to be randomly selected to take part in the Jivika administration, and the other half of which will remain status quo SNP. Similarly, with the technology-based monitoring, it's the same approach and same question. What is the impact of this new intervention on leakage of funds and child nutritional status? But because we want to be able to understand the differential impacts of top-down monitoring, bottom-up monitoring, and whether there's any incremental effect of combining the 2, we're doing a 4-arm randomized controlled trial where we have a control group with the status quo SNP, and then 3 different treatment arms in which randomly selected panchayats will either receive top-down monitoring alone, bottom-up monitoring alone, and both of them together. And the idea is that this is going to provide pretty robust evidence for the ICDS leadership and the Department of Social Welfare on how to most optimally use their resources to decrease leakage of funds and improve the quantum of nutrition that's being provided to mothers and children across Bihar. And just a quick note on the main outcome indicators. You know, the outcome indicator that's going to guide the decision really is leakage of funds, which is the intermediate outcome indicator. And the reason for this is that the main goal is to improve public service delivery. And also because this outcome indicator can be observed more quickly than changes in nutritional status, which take up to 18 months. But we will be doing a follow-up study to see if there's any impact on child malnutrition. And it's important to note that this might not change at all, even if the delivery of SNP improves. And the reason for this is that SNP may not be structured in a way that effectively targets children in the first 1,000 days, which more basic science research has showed us is the time where you see the largest gains in cognitive development and nutrition through these kinds of targeted interventions. And it may also be that these meals through the SNP are more of a replacement for meals at home rather than a supplement to them. And so, you know, I think there's two distinct challenges. One is, how do we optimize public service delivery of SNP? And then a second broader question of, if we can do that, are there still larger design issues where SNP needs to be more targeted to the first 1,000 days or be adjusted in other ways to really see the end nutritional impacts? And so that's the approach we're going to be taking over the next year. And, you know, we hope to be able to present a year from now on the results of this evaluation and the steps that the Department of Social Welfare and ICDS are taking to further improve the lives of mother and children in Bihar. Thank you.
I would now request Professor Anjini Kochar to make her presentation on improving child health and schooling and evaluation of the government of Bihar's Nayi Pidhi Swasthya Guarantee Yojana. She is the director of the India program at the Stanford Center for International Development. Before this, she was an assistant professor in the Department of Economics, Stanford. Her research focuses on the microeconomics of development and specifically on issues related to education, health, credit, population, inequality, and the effectiveness of government programs. Over to you, please.
Thank you. I want to start also by thanking IGC and particularly Professor Mukerji for his support for this program. And then thanking everybody from ADRI who's been collaborators on this, Shaival Gupta, known to all of us now, and Dr. Prabhat Ghosh, who was also there. Ghansham is somewhere in the room as well, but a lot of support from ADRI, and this is really in collaboration with them. So any praise goes to them, and I guess all the faults are mine, but that's the way it usually goes. Okay, so this was supposed to be a pilot study. Hopefully there's something more that has come than rather than the pilot. But was looking at this problem of child health. Okay, so the paper is actually a nice complement to the earlier discussion. I think it's going to pick up a lot of the issues on that and provide some quantitative analysis, but it fits in very closely to many of the issues you're raising. So starting with the ICDS data, for example, we know that child malnutrition and child health has been a major concern. And one of the reasons it's been a concern is exactly what was said in the earlier presentation. The health institutions, the local health institutions, do not function very well. So households, when services are provided through the ICDS or through the Anganwadi centers, households aren't going there. And so it's very difficult to deliver services to them because they are not visiting the centers to avail of them. So what has been the response to this? The response is actually also very similar to something they talked about. There's been an attempt by many governments, many developing country governments, not just Bihar, to move the institution or change the institution to deliver services. So in this case, we heard about this new initiative to move it to self-help groups, take it out of the institutions that are not functioning very well, move it to institutions that are known to function well, and self-help groups is one example. But the other example, and the more popular example, is to move the delivery of basic child health services, like child checkups, from health centers to schools. And the idea in that is that schools function fairly well compared to the local health institutions, in that at least enrollment rates are very high. So children do go to schools, and as a result of which you can deliver the health services to the children in schools as opposed to local health institutions. Okay, again, this may not work, and we saw some reason for that. Student absenteeism rates are very high. So that would be the prime concern, that we still aren't able to deliver health services to a large large number of the child population because of high student absenteeism. But the second concern, which has not been highlighted so much in the reports on this particular program, is the resource constraints you spoke about, that the number of doctors, the number of nurses, the number of personnel available to deliver these services is very, very low. And if the resource constraint is a fundamental constraint, then just shifting the delivery point from one institution to another is not really addressing what is a fundamental constraint on the operation of the program. Okay, so what am I doing? Let's jump on this. What am I doing in this program? I'm going to provide empirical evidence on those arguments. I'm going to do it in the context of a particular program that was introduced in Bihar last year. It's the Nayi Pidhi Swasthya Guarantee Yojana, a program for school health checkups. When it was introduced, there was a lot of fanfare, and the reason there was all this fanfare is because it was a universal program. So the program was touted as one that was going to deliver school health checkups to 34 million children. That would make it the largest program of its kind in the world. Okay, but what happened? Program coverage in the first year was very disappointing, very low. Average across the state was 44%, but you actually had some districts of the state with coverage as low as 6%, 9%, 13%, a lot of them with coverage just of 20 to 30%. Okay, so the initial results that came out trying to explain this, there was a lot of newspaper coverage, and the newspaper coverage attributed this to student absenteeism. Student absenteeism is very high, and so we aren't able to cover the students because they aren't showing up at the program. The two things that stand out immediately when you look at the data and suggest that that can't be the only story. So the first is that coverage is much lower than attendance. So people who were in school are not being covered as well. And the second thing is that if you look at some of the districts of the state, which are better off districts in that they have higher enrollment, better quality schools, well-functioning schools, the coverage of the program was very, very low even in these areas. So it wasn't just a problem in high absenteeism areas. Even in areas with high attendance, we got low coverage. And that suggests to me resource constraints. Okay, so what am I going to do in the paper? I'll establish the role of attendance. In doing that, it's actually very important to separate out individual attendance of the student from aggregate attendance in the school as a whole. And you'll see the reasons for that. If you don't separate out both, individual attendance is going to also pick up the effects of aggregate attendance. If you focus just on aggregate attendance, it's going to pick up the effect of individual attendance, and you're not really sure what you are estimating. Okay, I'm going to look at the effect of resource constraints, and this is where aggregate attendance comes in. And so again, it's going to speak directly to the paper that was presented before, give you evidence on that. There are two kinds of resource constraints that I'll identify. One is in terms of the population that has to be covered. So the number of doctors, for example, per population, but that's a fundamental constraint, it's a population constraint. And the second is also something that was alluded to earlier, that the health institutions, all institutions, are called upon to perform a number of different tasks. And that by itself is a constraint. You have a certain staff, and they're asked to provide both teaching, nutrition, cook the meal, etc. In this case, if you look at local health, the health sub-centers, they had to perform a number of duties. And this is just on a side note that as we get closer to elections, the number of new programs that is introduced increases exponentially, so that the duties they have to perform also increases exponentially with no increase in the staff. So adding on new programs can have a hugely detrimental effect, and that's one of the things I'm going to look at as well. Okay, so empirical challenges, there's a paper which is, should be available that will detail all this. So because of lack of time, I'm not going to spend too much time on a lot of the empirical work. But obviously, there are two major challenges. One is reverse causation. There's going to be an effect of attendance on the program, but there's also going to be effect of the program on attendance. And so you want to rule out reverse causation. There's also going to be just omitted variable bias, which is a standard form of bias. Okay, so how do I get around that? I'm basically going to use detailed data that we collected on the exact date of the school health visit, combined with monthly absenteeism data. So using the monthly absenteeism data, I create a pseudo panel data set, which has multiple observations for each student. The panel data set it has huge advantages over normal panel data sets because there's no issue of attrition. You have many, many observations, well, 12 observations per student. I actually have 24. But the frequency of the observations is very important. So identification relies very strongly on the fact that I have high frequency data at an interval of a month relative to the time span within which planning decisions are made. So health personnel, school personnel, that is done over the course of the school year. Because I use monthly data, you can actually remove a lot of the confounding effects of other kind of resource constraints. And that's spelled out of the paper, but I'll talk about it a little bit more. Okay, so I identify two things. I identify individual attendance. And for that, I use this multiple out-of-period observations and exploit the error structure in the equations, which again I'll show you. And then I identify aggregate attendance using the fact that schools were visited in different months of the year. There's monthly variation in absenteeism, and that plays into aggregate attendance coming out of this monthly variation in attendance and variation in the school day. The program that I focus on, additional program I focus on to look at this effect of having to do multiple things and how that affects coverage is the Village Health Sanitation Nutrition Days. Okay, the VHS&Ds were part of the National Rural Health Mission, but in Bihar they were introduced in the same year as the NPSGY. So there were 2 new programs introduced at the same time. They were run basically by the same institutions, and I'm going to identify the effect of having a VHS&D on coverage in the Nayi period Swasthya Guarantee Yojana. Okay, so in case I don't get get through the whole presentation, the main results. Individual attendance, as you would expect, increases coverage. If you're in school, there's a greater probability that you're going to be covered by the program. But the effect of aggregate attendance is negative. Okay? Why is that? It basically says that you have a large population to be covered. If that population is cut in half because of absenteeism, you're going to be much better off. Okay, so it's a very paradoxical result. And the paradoxical result is that we want to increase attendance to have more students covered. But unless you do something on the resource constraint side, if you do actually improve attendance, coverage of the program will fall. Okay, so there's a strong negative externality that is caused by this. Anything we do in terms, I'll come back to this later as well, in terms of schooling, in terms of health, if we are able to get households to use these to a larger extent, unless we solve a resource constraint, the quality of that coverage is going to come down quite substantially. So I also find a negative effect from the simultaneous VHS&D. So having multiple programs also reduces coverage. And then I do the reverse causation. We also want to know, did the program improve attendance? If it did, then of course individual absenteeism doesn't matter, they come in another day. I find no evidence of reverse causation from coverage to attendance. Rest of the talk, I'll skip over there. Okay, so the NPSGY. The way it works is it's organized at the level of the PHC, the Primary Health Center. There's a team of doctors at the HC that is combined with people from HSCs. There's a planning document which is made out for each district by PHC. And the PHCs then go from HSC to HSC, covering all the schools that fall within the jurisdiction of the HSC until they have covered all the schools in the area. Okay? One evidence of resource constraint is that the time given to a school is restricted to a day, okay, regardless of population. And that is exactly what you would expect if there is a resource constraint. The doctor is leaving his duties or her duties at the PHC, coming for these school health visits. You can't have them conducted over a long period of time. Okay, I wanted to show you an example of one microplan. This is for district in Kishanganj, and it's for a particular PHC. But what it shows you is the camp date is the important thing to note over here. In this particular PHC, it starts in May. The program goes through September. And so basically, they just work through all the schools, all the HSCs in the district, covering all the schools. I've aggregated the information, but they actually tell you which date each school is going to be visited, and you have the number of beneficiaries in each school. Within the area of a block then, which is the HSC, there's considerable variation in the month in which a school was visited. And that is what I'm going to exploit, that the month of the visit varies even within a block, and that's a substantial amount of variation in the data. The other thing you should note from this is the number of beneficiaries. The total in this particular this particular PHC was 51,000 students that had to be covered. On average, it means that 370 students had to be covered in a day. On average, that means that the time available for every child-specific health checkup is 1 minute. And if you have a 50% absenteeism rate, that just goes up to 2 minutes. Okay, so the pilot study I did was actually to see, the program was supposed to be to evaluate the effect of this on health. It became very clear to us very early that the program can have no effect on health. And that is actually what we verified through field visits going to households. They were not able to even fill up the report card on each student. I scrapped the idea to carry it through to a full evaluation because the program doesn't work. It doesn't make sense to spend a lot of money trying to show an effect on health when there is no effect. Okay, so that is really what is going on here. There's a massive resource constraint. So what I did do was turn over to studying the effect of this resource constraint on coverage. Is coverage low because of this and not really because of individual absenteeism? I went through all this. Again, the main point to pick up over here is the date of the VHS&D is also fixed. VHS&Ds are organized at the health sub-centers to cover all the villages that come below them. They run through the Anganwadi centers. There's a fixed date. It's supposed to be Mondays and supposed to be Wednesdays and Fridays. It doesn't matter. When there are more, it switches to Mondays, and they'll add on additional days. And I have data on the exact date of the village health and sanitation, which I will then combine with the data on the IPD. Okay, resource constraints is going to go very fast because you already talked about that. Population per HSC, 25,000, whereas the national norm is supposed to be 5,000. Population per PHC is 158,000, whereas the national norm is supposed to be 30,000. Bihar has that's gotten for APHCs, the additional PHCs, but even then it's 61,000 versus a norm of 30,000. Staff is constrained, schools are similarly constrained. A PTR of 52, pupil-teacher ratio of 52 as opposed to a national average of 33. And you can actually see the variation between states like Karnataka where the student-teacher ratio is 16 compared to 52. Okay, so huge variation across the country in that. Just a side note, because I get interested in all these issues. One reason for that variation is that village size in Bihar is much larger than village size in other parts of India. Okay, the survey data was 4 PHCs, 6 health sub-centers, and 32 schools. So as I said, the health sub-center works at the level of the block, and so we have 2 schools per block, and so we have variation in the date of the school visit across the blocks. This is the data on individual attendance. As I said, it's monthly data. And so the graph just shows you the variation in attendance across months, which I exploit in the identification strategy. And it also shows you that attendance varies across large schools, which is on your left, and small schools on the right. In large schools, there's much lower attendance compared to other schools. I'm going the wrong way, sorry. Okay, the empirical methodology, as I said, the theoretical framework, also in the paper, is a model of resource constraints. So given resource constraints, individual coverage varies with individual attendance, and then the resource constraints that are in operation. The resource constraints of personnel are being stipulated as being a function of fixed variables over the course of a year, a school year. And again, I'll show you that over here. It basically leads to a set of estimating equations. The C is for coverage. So coverage is going to depend on individual attendance. That's the probability of a student being in attendance on the day of the visit. It's going to depend on aggregate attendance, which is now the measure of resource constraints. It doesn't matter how many children are enrolled. What matters is how many children actually attend on a particular day. And then it's a function of a set of variables that are fixed over the course of the school year. So these could be PHC level variables, the doctors. It could be household variables. It could be school level variables. The probability of attendance is in turn a function of the coverage of the program. You know there's a program, so you might well show up because of that program. And then it's a function of a set of household-specific variables that vary by month, a set of month-specific variables, and then these same fixed components. So you can see immediately the possibility for reverse causation, and you can also see emitted variable bias coming out of these. Okay, so the identification of individual attendance, I use the difference in attendance for 2 periods other than the period in which other than the month in which the visit was held. Okay, so that immediately removes reverse causation because these are 2 months in which the program wasn't in operation. And that difference thing removes the effect of all fixed variables. So this difference term is going to be not going to be correlated with the regression error term in the coverage equation. Because of the availability of many months of data, you can actually use lagged and forward difference terms. So I construct several of those and use those as instruments, and that just improves the efficiency of the estimates. Okay, what about aggregate attendance? It's important to use, important to include, as I said, because otherwise the 2 effects are conflated in one. But it's also important because one of the things the differencing does not take care of is if there's school-specific variables that vary by month in terms of the effect on coverage. Because those variables are going to affect it only through aggregate attendance, if you include aggregate attendance, you remove that one concern with that differencing strategy. So how do I identify this? I identify this using variation in the number of school days in a month. Okay, so as we all know, whenever there are holidays, families tend to go back to the mother's village, and so you end up with much more absenteeism in the months in which there are additional school days. Okay, so that is basically the strategy I use, that you can use this exogenous number of school days in each month to identify the effect of aggregate attendance. Where am I going? Oh, the last part was this reverse causation, the effect of coverage on attendance, and that's basically a difference in difference estimator. I have data on attendance for the student for the year before the program was introduced, and so you can put in controls for the month of the visit for the school and still identify it, and so that is a way of estimating the effect of coverage on attendance. Okay, so again, quickly going to results. This table is just showing the first part, the effects of attendance on coverage. The first stage of regressions are there, and the first stage regressions essentially show you that we do have instruments both for individual attendance and for aggregate attendance, and so we're able to identify both effects. The last column is giving you the IV probit for the results. And those results show this positive effect of individual attendance on coverage and the strong negative effect of aggregate attendance on coverage. So the more students that are present, the probability of any student being, the probability of any given student who is in attendance being covered falls as a result of that. This is the second major set of results, and this is looking at the effect of the program itself on attendance. As I said, this is using 2 years of data, and so you can put in month fixed effects and control for any things that are specific to the month of the school visit, and still identify the effect of the program. So the main variable that you're looking at over here is this regression 3, just looking at the overall effect. Regression 4 adds on interactions with school size and with whether the child is from the scheduled caste or not. Essentially, you're going to find that there's no positive effect. There's a negative effect again of the program itself on attendance. And I can give you speculations for that. If you go on to regression 4, which allows this interaction, there is a positive effect in small schools. The magnitude of the estimates is such that it is really positive only in the very smallest schools. But other than that, in large schools, there's no effect of the program on coverage, on attendance. Okay, so conclusions. I think the fundamental constraint on the effective delivery of services, health personnel, resource constraints, they cannot be reduced by shifting delivery from local health institutions to schools. Okay, and that's a general finding, I think, that applies to many different sectors. And so I wanted to take a minute just to speculate on the implications of that for schooling. Okay, so I've already commented on the fact that if we are able to improve enrollments in schools, but we don't provide the essential resources that are required in schools, we're going to see a decline in school quality as a result of that. So unless we address resource constraints, shifting it from one institution to another doesn't make an effect. There are also implications for schooling inequality. And the results over here are saying that in worse performing schools, there's this negative externality from aggregate attendance. So students who do attend, who are the better off students, actually benefit from high levels of poverty in the village. Okay? If the schooling population is segregated or there's more inequality in that, the fact that you have 50% of students not attending schools benefits the 50% who do attend schools, and those 50% are the well-off population. Okay, so there's it comes back to something that I've seen happen a lot. There's very little incentive to do something about attendance in many different sectors. And the reason is that if you're properly able to do something about it, you are actually going to make the functioning of the institution much worse. So I don't think we've seen a lot of debate about schooling. Student attendance is not coming up in that. And I think it's a sort of a built-in mechanism because the schools function with high absenteeism. If you had 100% absenteeism, the quality of schooling in Bihar would fall off quite dramatically. Okay, so go back to the student-teacher ratios and all the other data that I showed you initially. Student-teacher ratios in Bihar are 50 to 1. With absenteeism, actually, it comes down to 25:1. And that is very much within the Indian average. Okay? The same thing with health subcenters. Population is 10,000 per health subcenter. With absenteeism and lack of use of that, those numbers actually come down to the Indian national norm. So when you go to schools in Bihar, you think, this is not that bad compared to Uttar Pradesh, compared to West Bengal, compared to whatever. What's built in there is a high level of absenteeism. And so there's a built-in policy thing almost, which says that it is not being addressed. It's a problem that occurs through all levels of education. So another paper I wrote was on a reservation system. And I raised it with members of the Planning Commission and other policymakers, and I said, I don't understand why we're doing something about scheduled castes at such a high level. Why don't we do something at the primary schooling level? And the answer that was given very frankly is it's a problem of numbers. We can't provide all the corrective measures to all the students who are enrolled in primary schools. But by the time we get to high schools, that number has fallen by 50%, and we can do something about that then. Okay, so that sort of thinking actually helps perpetuate inequality in the system. And that is, I think, the broader message to take out of this study. Thank you.
We were supposed to have 3 discussants, but unfortunately, both the Principal Secretary Social Welfare and the Secretary Health are not here. So Prachi Mishra will start the discussions. She is a senior economist in the research. She was a senior economist in the research department at the IMF. She is currently on leave and is a senior economist in the office of the Chief Economic Advisor of the Ministry of Finance. She is a PhD in economics from Columbia University, and her research interests are in the areas of international economics, macroeconomics, and political economy. Prachi, over to you.
Patna is my hometown. I have strong connections to the place. So I was, unfortunately, the two people who mattered more than I do are not present. And I was supposed to discuss one paper, which is Ron and Buddy's paper, but I've been asked to, make a few comments on the other paper as well. So I'll actually do some slides on the paper I was supposed to discuss, and the other paper I'll just try to make some comments. So what the paper does, to summarize, I think it was a very nice presentation and described very well. So the paper evaluates the ICDS supplementary nutritional programs across 3 districts in Bihar, Muzaffarpur, Gaya, and Madhubani. So the methodology is basically the surveyors made unannounced visits to 200 Anganwadi centers. And the main message from the paper was that there's very strong evidence of leakage. More than 50% of the funds overall do not reach the beneficiaries. And there are some additional consequences like a poor nutritional quality of meals, poor attendance of staff and children, poor learning, etc. So, first of all, the paper addresses a very important and a very relevant question. I think Bihar is an ideal case to study the effect of programs of this kind, because as the speakers talked about, the malnutrition levels are alarmingly high and greater than the all India average. So if you should expect any effect in any of the states, probably you should expect to see an effect in Bihar. Of course, it's very relevant. We know, what recently, what happened to, programs like this in the midday meal scheme. 23 children die in Bihar, 66 girls ill in Tamil Nadu after eating midday meals. So, there's a plethora of programs like this, and, there's a growing concern about, what the objective of the program was and what we are achieving. On the methodology, I would be a bit careful and not overreach with the conclusions. First of all, evidence from these 3 districts, Gaya, Muzaffarpur, and Madhubani, I don't think can be generalized across Bihar. I think there are significant differences across the districts, and this should be highlighted. So the results are important, but I don't think the authors should try to overreach. I would take the evidence as mainly descriptive and would not draw any causal implications. It would be hard to claim from what you showed that low nutrition levels are because of the Anganwadi center's performance. And I think the paper is very nice. The results are good. I think it would be good not to overreach the conclusions. The main thing is the results are not surprising. There's now plenty of evidence of leakages in government programs, a detailed study of the Planning Commission itself on these Anganwadi centers. So I was not surprised about the results. Of course, that you quantified it for these 3 districts in Bihar is important. What is surprising is that this program has been running for more than 35 years, and still it's not working. And still there are huge leakages and plenty of problems with the program. So, the big question to me seems to be that, are these programs, designed to be, there's a flawed design in the program, in, such kind of programs in general. And that has to be, there needs to be a fundamental rethinking of the programs rather than, quibbling about a few things here and there. And basically I see 4 fundamental issues in the design of these programs. Having talked to myself to these Anganwadi workers and having known them anecdotally, they have no incentives to perform, basically. They have absolutely no incentives to not cheat. The monitoring does not work, of course. But I think the more important thing is about, and some of it you already talked about, is about information. Beneficiaries have absolutely no idea about what they're entitled to. And, and even if in the few cases they have an idea what they're entitled to, there's no grievance redressal for beneficiaries. So even if they know how much they should get, what quality of food they should get, if they do not get it, they cannot do anything. And the fourth one is, of course, this appointment and removal of this Anganwadi center staff is extremely flawed. There's no proper framework. There are a huge number of court cases in the Patna High Court on the appointment and removal of these sevikas and sahayikas. So I think it was never thought of how these would be appointed, how they would be removed. There was no proper thinking on this. So in my view, I think overall a top-down command control approach has not worked till now, and it is not likely to work. That is, the state government saying that we want to spend so much on this program, we want the malnutrition to be removed by so much, has not worked, and I doubt that it's going to work, in the future. So on all the four fundamental issues, first, unless you give incentives, for example, the Chhattisgarh PDS works as the ration shop agent gets a commission. So there has to be some incentive mechanism built for the sahayikas and the sevikas to perform. The second point is that, I think there needs to be a massive information campaign to educate the beneficiaries. Unless they are aware of what, they are entitled to, it's not going to, the system is not going to work. So it has to be a demand pull system which can be self-enforcing. And there has to be a demand from the beneficiaries for monitoring. Third, quick grievance redressal. I think the courts are not going to, I think the Patna High Court or even the district courts cannot take grievances from the beneficiaries of Anganwadi centers. They are too overburdened. So one has to think about, what the grievance redressal mechanism has to be, and it has to be quick grievance redressal mechanism. And finally, there again has to be a rethinking of the framework for appointment and removal. We know that, there's a lot of corruption going on in the appointment and removal of these staff, and there has to be some rethinking of the framework for this. So with this, I'll just move on to the other presentation by Anjini and make a few comments. Again, an example of another program, Bihar Nayi Pidhi Swasthya Yojana program, which is not working. So again, it's not, it's very good to quantify the results, but the results are not surprising. And ideally, these people who are in charge of both the Secretary, Social Welfare and Health should have been here to see these results and see what can be done. So again, again for the same, for Anjini's paper as well, why is, again, unless it's a demand pull approach, that, the beneficiaries demand health checkups and they realize what it means not to get these health checkups, then only, we are, the kind of programs are going to work. And of course, this has to be combined with grievance redressal. The other point on human capital and, aggregate resource constraint. I think Anjini talked a lot about, the quantity of human capital and, the resource, aggregate resource constraint. I think what is important is not only the quantity of human capital, but also the quality of, these health personnel who are there. And what are they doing? I would like to know a bit more about, what are they actually doing when they when they do these health checkups, and what happens after these health checkups? If a child is identified, how is a child identified to have what problems, and is there any follow-up? So I would like to hear a bit more about, this program, these health checkups. What do they mean? Are there any follow-ups? The quality of people who, do these checkups, rather than just the quantity of the resource constraint. So just a few comments on the econometrics. So Anjini basically uses aggregate attendance as a proxy for resource constraints. So I would actually, rather than doing that, I would also try to include some direct measures of resource constraints to see, whether these results hold true. Because the whole point of the analysis is that, you know, the number of health personnel is very important in determining, if you have higher aggregate attendance, you actually get lower coverage because, you know, you get a lower health personnel per student or so I would use other proxies for aggregate resource constraint to see whether the results hold true, just on the methodology part. And then on the instrumental variables, I would also like to see the first stage F-stats. I could not make the economic significance of the results from just looking yeah, so I didn't have time to look at the paper. But overall, again, you know, my overall comment on the paper is yet another program which is not working. We can keep discussing it among, you know, an academic kind of an audience. How will it be translated to the policymakers, and what is exactly to be done when these programs have been, particularly the ICDS Supplementary Nutrition Program, which has been working for 35 years and has not yet worked, is something we really need to think about. Thank you.
Thank you. I would request first Neil and then Anjini to briefly respond to the issues raised by Prachi before we throw the discussion open to everyone in the hall. So Neil, please go ahead.
Thank you. Prachi, thanks for the insightful comments on the paper. I think you're absolutely right that this isn't necessarily groundbreaking evidence. I think it's something that the ICDS and Department of Social Welfare leadership knew even before asking us to conduct the study. And I think the most interesting part of what you said is that, is there a fundamental redesign needed? And you outlined 4 big issues: no incentives, lack of information, no grievance redressal, and no framework for the appointment and removal of the AWC staff. And I think that what the interventions that Ron had spoken of, which the ICDS and Department of Social Welfare are going to try now and then evaluate, address all 4 of these in some form or another. I think the big question is that, you're right, it's very hard to punish or reward staff within the system. And I think that's the kind of reform that doesn't seem to be politically saleable in the short run. And so what can we do about it, given the fact that there are political constraints preventing that? I see the Jivika administration of the SNP as a way to sidestep that political constraint by saying, look, we can't set up a new system of incentives for reward or punishment with the staff, but instead we can ask this other organization, which seems to be in a higher equilibrium of delivery, to actually take on this role. So I think the first and fourth point that you made are hopefully might be addressed through the Jivika administration. And then the second and third points around lack of information among the beneficiaries and no grievance redressal, I think the monitoring programs are designed to address. And you're certainly right in saying that there have been few examples of top-down monitoring, if any, in India that have been successful. But I think the bottom-up monitoring approach holds a lot of promise, both because it, A, simply provides information to beneficiaries on what they should be getting, and provides information on the performance of their Anganwadi center compared to national or regional averages. And then it also gives them 2 forms of grievance redressal. The first is that as there's more awareness among the beneficiaries, they're more able to put pressure themselves, right? So it's not that they need to air their grievances to some other higher authority, that they can actually be empowered just through this better access to information. And the second is through some kind of call center where beneficiaries can actually report on the performance of their Anganwadi workers. There is a more formal route of grievance redressal, which I think, you know, may tackle the issue both from the kind of bureaucratic management standpoint, as well as the Anganwadi workers responding to the needs of the beneficiaries themselves. So I think that, you know, you're exactly right in the issues that are there for redesign, and hopefully some of these interventions might tackle those issues, but I think it remains to be seen how well those are implemented at the end of the day.
Thank you very much for your comments. I think Neil covered quite a bit of the things. I just wanted to touch upon one thing, which is that I think it's very important to understand the fact that bringing about reform is extremely difficult. So just take a case in point. You mentioned there are lots of court cases that are pending in the High Court in Patna. Now, the ICDS director can't really change the lawyer that's fighting for them. The ICDS director can't hire a better lawyer. There are always restrictions that the leadership faces in trying to address these issues. And I think it's always important to just be very cognizant of the fact that while the ground level situation is extremely, there are problems, bringing about reform is also just as difficult. And it's commendable that they are, the sort of initiatives they are taking and employing a very careful learning and evaluation approach to ensure that the initiatives they're taking can have maximum impact is definitely a commendable exercise by them, and it's something that I know a lot of departments in Bihar are already doing.
So I think she's given a copy of the paper just as she was sitting at the table, so she didn't even have a chance to read the paper. So I wanted to correct some of the statements, because I think if you had more time, you'd have seen that. The first was, yeah, I definitely agree that there's nothing to be, if I just told you that the program doesn't work and coverage was very low, you would all agree that that's a very uninteresting statement. You know that from many other programs. But the paper did really make a serious attempt to try and show you why it was low. And it related it and provided, I think, one of the first sets of empirical evidence of resource constraints and of the multiplicity of programs affecting coverage. I think that that causal identification is the real contribution of the paper. Speaking to aggregate attendance, that again I think is one of the strengths of the paper. We think of resource constraints as the population covered per whatever it is, so population per bank branch, population per school, population per health center, that really is the resource constraint, or population per doctor in the health center, that is the resource constraint. As you know, when you try and estimate the effect of that resource constraint, it's very difficult. So for example, for banks, if you take the population per bank branch, that's basically the village population. And village population is going to have all kinds of effects on the program apart from this resource effect. It's very difficult to separate out the two. As a result of which you don't see papers that evaluate resource constraints. Instead, we see a lot of randomized interventions on small things. But when you get to universalization, resource constraints are important, it's difficult to address. What allowed me to address that over here? First, it was the recognition that the resource constraint in this case, which is the population per health subcenter or the population per school being visited by that school team, it is not enrollments, it is attendance that matters. It's the number of students who are in attendance on that day. That really is the resource constraint. The variable you want to be thinking of, the resource constraint variable, is the number of children present in the school per health team. So how many children that the health team has to cover. But because of the strategy I use, you can basically hold constant the health team members, and the variation comes then from aggregate attendance. So what aggregate attendance is doing is not just thrown in there to say, I'm just looking at the effect of aggregate attendance. Aggregate attendance is the resource constraint we are interested in. I mean, what it is really picking up is what is the effect of one doctor having to cover 370 students on a given day. And that exactly is the resource constraint. I think it is able to provide that evidence again because we are using, because in this particular case the resource constraint is not just given by enrollment in schools. Enrollment in schools is the size of the village. And to have papers which tell us, the size of village matters, I know the size of village matters, but it affects everything that's going on, not just this program. But because it is aggregate attendance and because you can actually identify the effects of aggregate attendance through the data we have, you are able to get a very precise measure of resource constraints. And so you're actually able to provide quantitative evidence to people who do say that what is really affecting the functioning of the programs are resource constraints, in this case, lack of doctors, lack of personnel per students that have to be visited, and the multiplicity of programs that are going on with the same set of resource constraints. The policy recommendation from this is the government would have been much more effective if it had not introduced the VHSND, or if it had not introduced the Nayi Swasthya Yojana. The two programs, and the reason I picked them up, they do exactly the same thing. They provide health checkups. They were just done in two different ways, and because of doing them in two different ways, neither of the two is effective. To go back to what you started with, that you wanted information on what exactly is being done, this is another paper I wrote with Dr. Kochar on this. There are health cards that have to be filled in. We actually went to the households and asked for the health cards. The health cards are not filled in. There's a 3-page health card, and it's not filled in at all. And the reason why it's not filled in, they have a minute per student. You can't do it. And so in many cases, it's not done. There was one case when we saw that there were a few times that it was filled in. There was one case when the child was diagnosed with a neurological disorder. The card was sent back, and so I think it was noted because it was obvious the child did have severe health problems. We asked the mother and said, did you know about this? Did you know that this is filled in and that your child needs treatment? But nobody had told the mother. And so even though the health card was at home with the mother, no further action had been taken. What the government is saying is that what this health card system allows you, the school health checkups allow you to do is there's a referral system that goes along with it. It is supposed to, and the reason why the program got so much emphasis, once you get diagnosed with an illness, you're supposed, in theory, to be able to go and seek a remedy for that, not just at any government hospital, but at any private hospital, and the government will cover the cost for that. So it really was seen as a revolutionary scheme. When I read about it, I said, this is fantastic that we have this. The reality is very different, and I think, again, what I was trying to do in the paper was to point out exactly why the reality is so different from what we expected.
And half of the kids were not there. You thought of that as a leakage. In midday meals in Delhi, for example, you go to schools, and of course, everyone isn't there. And what happens is that children in higher grades often eat that food. So if the food is there, then it's, is it that the food isn't there, or is it there but the kids aren't there? If the kids aren't there, someone is eating it. And if they are, then I don't know if leakage is quite the right word over here. Again, to the extent that food costs more than is budgeted for it, I don't know whether leakage is the right word. So I want you to think a little bit more about whether these are all leakages out of the system or they're just going somewhere and you're not measuring them. On your thing about monitoring, so one argument you made is there's just not enough monitoring. And I had two comments on that. One is that when you're thinking of Hindustan Leader and you're thinking of schools, it's quite different because there's really, the local community cares about the schools. They don't really care whether Hindustan Lever is selling more soap in their village or not. And so I think implicit is the idea that we expect some local monitoring in some form or the other. And that's really what to rely on. So that was there. And on the monitoring, I would just like to hear the Bihar government people on this, because certainly, some different approach to what we are supposed to Bihar success. So just making people think that their job is what they thought it was, and they need to deliver in a way that's different from the way they were delivering. They need to be more caring, more accountable. Is that really monitoring each thing more over there? In which case, are we making too much of incentives as opposed to other things? And I wouldn't, I wouldn't expect these mothers to know what the Hindi word for malnutrition is. I certainly don't. And so, they know what malnutrition is without necessarily knowing the stilted formal Hindi for it. On Anjini's, this resource point again, what seems to be coming out of this is that it's incentives and resources, and both these things matter, and you have, Anjini places emphasis on resources. Are these monthly health checkups? Yeah, so the question is again, what can we do about the resource constraint? And this is of the Indian, where rather than lower level health, just measuring heights and weights, people could do hemoglobin. A lot of things can be detected. And if you can't, if you have, 2 minutes a year, maybe you could do 4 minutes every 2 years. I mean, I'm just pointing out that might not be taking as given the set of people do, and the frequency with which it's being done might not, you might want to think about changing those parameters, given that the resource constraint is there. Sorry, that was a bit long.
I'm R.K. Verma, and I have a simple observation on all the papers presented here. The issue of resource leakage, the issue of corruption, the issue of inefficient service delivery has been a story of last 2-3 decades in developing countries. I'm very much impressed by the paper presenters. They have presented very, very nicely. But I have two self-contradictory observations to pass. The one is that if these programs have been not delivering well, why all these programs continue in the countries of third world, still continue. And the second observation is that even then, people like to continue these programs, maybe ICDS, even PDS system, public distribution system, all are in existence despite all ills. Now my hunch is, going to evaluate the outcome of programs, any researcher who is addressing the development issues in a country like, in a society like Bihar, should examine the administration and management aspect which tells upon the outcome of the programs. So why didn't they address the managers of these programs? What they lack, why did they lack, why the resources are being leaked out in the market? All these questions are more important than using complex statistics to show that these programs are not working. This is my hand. Thank you.
I'm addressing to the first presenter. Sorry. Have you seen the growth rates of weights or the absolute weights? Because absolute weights doesn't make any sense in the sense, I mean, because you are not tracking their developments. This is one issue. And for ICDS, I know of some states where age recorded are not right. If you look at the registers, and this data is available with ICDS, the growth rate of the weights, because they take weights, they're supposed to take weights. Secondly, about the sampling technique which you have used, I'd like to know about the sampling technique in the sense, like if you have used random sampling, there might be some error because there are a lot of variation across various ICDS. If you look at the slum area ICDS, rural ICDS, urban area ICDS, there are a lot of variation. You might not find a fan in an ICDS center. So this needs to be seen. And for leakage, I completely agree with what Rohini said. You need to judge leakage in terms of a dynamic setting. Leakage cannot be judged in a static one-day visit because mode of purchase of the commodities, how it is distribution pattern, timing of the Anganwadi centers. Very often, there is no uniform time for many Anganwadi centers. I don't know much about Bihar, but for many other states, I know that they don't have a fixed time. There are variations in time. So you got to see this, if necessary, might be randomized over time, certain things are needed. So all leakages and incentives are to be calculated in terms of a dynamic setting. This is my submission. Thanks.
The problem is not so simple. There are a lot of dimensions to it. First of all, I would like to introduce myself. I am Dr. N. Vijay Lakshmi. I am Secretary to the Government. I am presently working as Secretary BC and EBC Welfare. So if we can just go back, little bit in history, in 2007-8, the erstwhile welfare department was, divided into social welfare, BC, EBC welfare, and SC/ST welfare. So the social welfare secretary is not present today, but I had the experience of working as ICDS director 3 years back in 2010. So from that experience and the practical problems which we have faced, I can suggest certain things. See, the issue has to be handled at various levels, and there are a lot of problems related to this ICDS thing. And if you actually see it, from a practical perspective, there are structural problems, there are functional problems, there are financial problems, which means, the entire model has to be actually restructured. There are human resource issues, and there are also a lot of infrastructure related issues. So it is so complex. It is not so simple. It is not just about leakage of funds. But if one has to really reform the entire system of ICDS, its delivery, one has to actually look into all these aspects, all these 5 aspects. Let us look at the structural aspect of it. Here we have only one social welfare department. But in the Government of India, we have a Ministry of Women and Child Development Department. So we actually don't have a department which actually look into those issues. We don't have a women and child welfare, but the social welfare secretary has to attend meetings with the WCD department, Government of India, and also other issues related to the social security, social defense. So he has to attend meetings in Government of India with social justice, the Ministry of Social Justice and Empowerment. So it's actually, there is lack of alignment between the state government departments and the central government department. It is high time we should have a Ministry of Women and Child Development Department to actually take care of issues related to women and children issues and focus only on these two target groups. That is one point. And the other issue is, when the ICDS program has been started since 1974-75, and since then the Government of India has been sporadically, sanctioning the ICDS blocks. For example, in the 70s, to begin with, the program was started with the help of, with the aid of World Bank assistance. So initially they started 10 to 20 blocks, sanctioned 10 to 20 ICDS blocks. Later on, they kept on increasing, and now we have ICDS program running in all 534 blocks. While designing the program itself, they should see one ICDS block is sanctioned, which means that there is one CDPO. But what is the support system with the CDPO? There is no support system. It doesn't mean that you have just sanctioned one CDPO post and don't give her any support staff. So how she will work? So that is one systematic error or systemic error in the design of the program itself. So these are issues. There are a lot of human resource development, human resource issues. Like there is a supervisor layer which was sanctioned later on, but those posts were not recruited. When I was there in the ICDS program, we started recruiting those supervisors. But again, you have to take decisions very quickly and very dynamically. If you give it to the district administration to recruit 3,000 people, I'm sure it takes 3 years. And to my horror, I've come to know that the recruitment process is still on and 3,000 people were not recruited. So you have to take different kind of decisions. So that is one important issue. And the other very important issue about this leakage of funds, it is about the model itself. See, this is the only state in the entire country which gives 10 to 11,000 rupees in the hands of the Anganwadi worker. The Anganwadi worker who gets only 1,000 or 2,000 rupees honorarium cannot actually handle that kind of an amount with all her honesty, So those are the issues, and we should not actually give money into the hands of the Anganwadi workers. Instead, there are a lot of other alternative models which can be, thought of and which can be implemented. So we have actually recommended a lot of other models, but those were not, thought about. So what is very important is changing the entire model and also making the system leakage proof as far as it can be done. Okay, there are a lot of issues, and but at the same time, you cannot just give money into the hands of the Anganwadi worker. That is very important issue one has to actually look into. And at the same time, there are a lot of infrastructure related problems. So, there is an Anganwadi, we are running in the state, we are running 91,000 Anganwadi centers, but a lot of Anganwadi centers do not have a roof for themselves. So there are a lot of issues. So, and at the same time, the entire time of the Anganwadi worker and the Anganwadi helper goes into only making khichdi. So that is not she is supposed to do. She is supposed to do so many other functions. She has to take care of mother's health. She has to take care of the child's health. She has to actually take care of the early childhood education. She has to take care of immunization.
Dr. I think you touched upon a lot of the issues, and as having been a practitioner, I think you deserve more time, but unfortunately we're coming to the end of the session. There's a gentleman right at the back who's been raising his hand, so let's hear him also.
That is what I just wanted to actually, bring about issues which are actually there.
No,
so
I think
it doesn't make any sense only discussing what is there and what are the problems, what are the leakages.
We can do it over lunch also. I would request now the gentleman at the back, please give him a mic, and please introduce yourself also before saying what you want to.
Yeah, my name is Sadat Noor and I represent Population Foundation of India. A couple of quick observations. One is, I think Ma'am Prachi Mishra had pointed out that they don't work. The system, the current ICDS system or the health checkup system does not work. No, I strongly disagree, they do work. They might not be working the way we want them to work, but yes, they do work. And coming from, having worked with the ICDS and the health programs, both in Bihar and other states in India, I know how effective they have been and how, no, probably not that efficient, yes. Having said this, I would also like to ask probably somebody here that there is a 40-child norm with the ICDS in Bihar, meaning that one Anganwadi center cannot take more than 40 children, even if there are 50 or more than 40 children within the reach of the Anganwadi center. These 10 children are left behind, and this is one of the basic reasons why the beneficiaries have to look for the favors from the Anganwadi centers and the Anganwadi Sevikas, and the gaps are not then reported back. That is one. The second is that why is it that VHSND and THR are not being done on the same day? VHSND primarily is for health and nutrition as well, but we see very typically in Bihar that VHSND is happening on some other day, Mondays and Fridays, whereas THR happens on any other day except Mondays and Fridays, creating a confusion and creating also the lack of convergence that VHSND in the first place was designed for. So we don't see any kind of a convergence there, and that is why we do not have either VHSND getting as effective or THR getting as effective as they should have ideally been. And thirdly, I would also want to ask, have you been able to assess the Uddipan program that the ICDS has recently introduced? So when we see that now the ICDS is shifting from the sectoral approach that was having lady supervisors for every sector to Uddipikas, which is coming down to the cluster level, I think the efficacy of the program would be much better. And I very strongly feel that the role of the Uddipans and the Uddipikas should also have been pointed out. And how effective is it going to be? Yeah. Thank you.
Thank you, sir, for giving me the opportunity. I will first congratulate the paper presenters. Very good presentations have been there. I have two very brief observations to make here. Why, for the last decades, ICDS data, huge collection of data, are not used properly in the name of bad quality of data? Number one. Number two, regarding the Anganwadi workers, the Sevika and Sahayikas, their deployment and appointment and the process thereof. Sir, I have been working with them for some time, 3-4 years back, and I came to learn that the Sevikas and Sahayikas, they are not simply the Sevikas and Sahayikas. They are care of some VVIPs of the community, of the local community. And one of the findings that we saw here, 40%, in 40% cases, the two were found present. They don't bother much for their delivery, for their efficient working, for their efficient functioning. And it is equally important that who they are, they must learn why they are. Thank you, sir.
I'm Ghanshyam Tiwari. I'm a researcher with IGC. I'll be presenting on flood management tomorrow. My question is on the ICDS study. I would be interested in learning more about the current mapping of stakeholders. When one talks about leakage on a scheme that has been going on for such a long time, my sense is that maybe the stakeholders of the scheme on the ground have changed from the stakeholders that the scheme was designed for. Because there seems to be certain harmony on the ground. Who are the real stakeholders on the ground, and maybe they are satisfied and that's the reason that the scheme is going on. And two, if there's data that suggests how does the ICDS leakage correlate to number of children and maybe the economic or social strata of the community.
I'll request both sides to briefly respond, not more than 2 minutes each, because we are standing between everyone and lunch.
Thank you, everyone. I'm going to start about, so there were a few questions on measuring leakage. So when we did go to the Anganwadi, we counted all the children that were there and not just those that were enrolled. So we ensured that we didn't just look at the enrollment. Secondly, we weighed all the food. Thirdly, someone said that it should be dynamic. I'm going to be very quick. Thirdly, someone said that it should be dynamic. I completely agree, and that's what we did. We looked at the procurement process, the cooking process, and both of them and the attendance, and a lot of all the factors that can come in. And whenever there were assumptions we made, we always ensured we were on the conservative side. Another point that I wanted to talk about was on the assessment of nutrition. Someone said that it should be done as a tracking-based thing. I think when you are trying to address the problem of nutrition as a management tool, you do need to track nutrition as a dynamic basis. Here we were just trying to assess whether what was the status of nutrition. So it was actually not it was not over time, it was sort of a cut of the time. I agree. Before I hand it over to Buddy, I just wanted to, there was a few small points that people made. We have not been able to look at the Deepika study intervention, so we don't have, we've not been able to research that. You mentioned something about the beneficiaries not knowing about malnutrition and the word kuposhin. So they do understand the word for diarrhea, but they do not understand that the underlying predisposing factor could be, or is very likely to be, malnutrition. So when you look at a child who's malnourished, it's not immediately evident to anyone, to any layperson by looking at him or her that she's malnourished until he or she is severely acutely malnourished. That's when it's fairly evident. So that's why we were trying to stress the point that malnourishment is not considered a major issue. Okay, with that I'm going to hand it over to Buddy.
Just on your point about, yes, one of the assumptions is that the incentives are wrong in the system, and some of the interventions that we're working with the leadership on are trying to address that. I think you're right in saying that there's potential for kind of intrinsic motivation to change and for that to improve the system. And we're certainly not working on that, but I think that'd be a very valuable line of inquiry to continue with for the leadership, to try to think about how do you induce behavioral change among beneficiaries and workers to have more intrinsic motivation rather than top-down monitoring. But I mean, I think the global evidence shows that it's pretty hard to do that kind of behavior change. Not that it shouldn't be tried, but you know, I think it should, but I think it's difficult. And then I think the gentleman over here said that, you know, researchers should look at the administration and managers of these programs rather than just doing statistical tests. And I think there's a lot of truth to that. I would just say that I don't think they're mutually exclusive approaches. I think that you can have quantitative studies trying to measure the impact of a program, but then there's a very clear need to have ethnographers or political scientists or sociologists do more in-depth examinations of what exactly happens in this black box from an idea to an outcome within the bureaucracy. I think that'd be a very valuable place to do more research. And then the gentleman from PFI, he said that he does think ICDS works, maybe not perfectly, and yeah, I think that we'd agree too. It's not that they're doing zero, it's just that they're not performing at kind of the benchmarks that have been set out initially. And then he said, you know, there's a 40-child norm, and there might be more children within that catchment area that could go. And I'd say that, you know, if that were the case, then maybe, so you're implying that there's greater demand for those 40 seats than there's a supply. But what we actually find is that on average, only 22 children are in attendance at the average Anganwadi center in these 3 districts, which makes me think that maybe there isn't an over demand for these 40 seats, and that might not be the source of the Sevika's power vis-a-vis the beneficiaries. And that's it. Yeah, okay.
Between me, you all on lunch, but just a quick response to Rohini's comment on the resource constraints. Definitely the program is just looking at the way it is implemented now and saying in the current implementation are resource constraints an important part of the story, and the answer is yes, it is. Can we do something about the resource constraints and can we minimize their effect? Definitely. Again, very much along the lines that Rohini was suggesting, we could go with different levels of health workers, we could change the frequency, do it once every 2 years. I wanted to point out a different part of the program that was not carefully thought out. So I guess what I was saying is that we have a set of resource constraints. You can build around the resource constraints and then design a program that is effective, taking those resource constraints into account. That was not really done. The program was just implemented without sort of working on what it's... The point I wanted to focus on was this fact that the program, because it is using the PHC team, spreads out over 5 or 6 months in any particular block. And a lot of those months are high absenteeism months. Maharashtra has a similar program. The Maharashtra program is run with local health workers, and the program is concentrated in 2 months, which are high attendance months. So just by shifting from high absenteeism months to high attendance months, you could have improved coverage rates by 10%. Okay, so that's just a simple implementation issue, which could have had a massive effect on the program. In fairness to the government of Bihar, I should say that they realized immediately that relying on these PHC teams was a problem. And so in the continuation of the program, they are looking at using the Ayush doctors and local health functionaries. But it raises a separate issue, and that issue is that when households know that health programs are being delivered by local people, the demand for the program is affected. Having a doctor from the PHC is very different from having somebody, an Anganwadi worker, deliver the same very routine services, and how that will affect the functioning of the program, again, is a question that has to be.
There's been a lot of very provocative presentations, meaning not thought-provoking, I would say, not provocative, thought-provoking presentations. And it also goes to show that the Bihar government is searching for answers. There is a concern, there's a lot of money being spent, how to make that public expenditure more efficient, more effective. And this public spending is on a massive scale in a very unequal society. The power structure in the village, there are a lot of ramifications of that. And the challenge is how to make these programs reach the bottom 30%. I think some of the studies that were presented today and will be presented in the subsequent sessions, they're all focused towards evidence-based policy making. What works, what doesn't, finding out, and in what setting. What are the goals? Then we have seen that the intentions are good, but that is not enough. There is a saying about something being paved with good intentions, which I will not go into. But we need to see how to better implement these programs. First of all, the goals, the design, and then the implementation. Especially when we are working in the situation we are in a very poor setting where there is a lot of poverty and very disempowered. They can come to the Chief Minister's Janta Darbar and make their complaints. They are empowered to do that, but before an Anganwadi worker or before a health worker, they feel totally disempowered because at that level they are not able to be heard. So these are challenges, and I think there is a battle to capture the public perception, to make them aware that these are the programs they should avail of and take advantage, so that and I hope that though unfortunately our Government of Bihar officers concerned could not make it to this, I am sure that these presentations will reach them through the IGC, and they will think of remedial measures. We also look for solutions. Thank you, everybody.